Morning, everyone, and welcome to the House Committee on Health and Human Services and Elderly Affairs. We have three bills that we're going to be hearing that have come over from the Senate. But before we get into those, I'd like you to please join me in the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you, everyone. First bill to be heard this morning is Senate Bill 127, and I'll recognize the prime sponsor, Senator Jeb Bradley. Morning, Senator.
Good morning, Mr. Chairman, members of the committee. Pleasure to be back here. I sponsored this bill, as I've done for, I think, the last 3 or 4 sessions for the Department of Health and Human Services to make certain technical changes, and this is largely a technical change bill. Passed the Senate unanimously, as I recall, and I bring it to you. I can walk through very briefly what these changes are. There are some 10 or 12 of them, but I think your time might be better spent hearing from the department who asked me to file the bill. So with that, I'll take any questions, or I can, touch base on what each of the sections does, but I think John Williams will do a much better job than me, if that's all right with you, sir.
Sure. Attorney Williams has made that offer, and he's indicated there are a number of people from the department to do so. While Senator Bradley is before us, does anyone have a question for him or any questions for him? Okay, I'm seeing none. So,
and I would just thank you again for the very gracious hearing last week on Senate Bill 263. I appreciate that very much, and thank you for that.
Okay, thank you. See you. Okay, Attorney Williams, would you like to come forward? And I guess you have quite a cast with you today.
Chairman McDonald and members of the House Health and Human Services Elderly Affairs Committee. For the record, my name is John Williams. I am the Director of Legislative Affairs for the New Hampshire Department of Education, not really, but Department of Health and Human Services. And I wanted to thank the committee and also our prime sponsor, Senator Bradley, for bringing this important legislation forward. And we look forward to presenting this to you. You may recall last session we did bring Senate Bill 430. That bill had 73 sections. The bill before you I have to report to you that has 16 sections. So we did get the memo on making sure that we were more tight and that we made sure that the appropriate subject matter went to the respective committees. So contained in this bill are issues, subject matters that would be relevant to this group, and we thank you for your time and appreciation. So as I walk you through the legislation, we're going to start with sections 1 and 2 of the bill, and that begins on page 1, lines 1 through 18. And you may recall, for those of you who served on the committee last session, that we brought before you a request to establishing a dedicated fund within our opioid treatment prevention program. And at the time, you did establish the fund, and as we learned after the bill had been signed into law, it could have been fixed through an enrolled bill process, but there was an incorrect cross-reference to the legislation as to where the fees would be collected from. So fees are collected in support of the program through a provision under the Controlled Drug Act, and it allows for the department to use those fees that are collected to support the program activities around the opioid treatment prevention program. So the underlying policy for that change was adopted by the legislature and passed this committee, but we're here today to correcting the improper cross-reference and getting you to the correct cross-reference as it relates to that particular section. And I would just draw your attention on sections 1 and 2. First, starting on line 8, you'll see that we're making the appropriate cross-reference to the fund that you created under RSA 172.8 C, within the Controlled Drug Act section where the fees are established, and then made the appropriate cross-reference within that particular RSA in the fund so that the funding source matches up with the funds. As I go through this, if it's helpful, I could break for questions and then move on to the next section. So I see no questions.
Any questions so far? Okay.
Right. Well, that will take us up to sections 3 and 4, and I'd like to invite up at this time Attorney Brian Clark, and he is general counsel within our legal and regulatory services, but particularly he's here on the sections 3 and 4 as it relates to his role as general counsel for the Bureau of Elderly and Adult Services. And so sections 3 and 4 of the bill address a workforce capacity issue. You may recall that you folks passed legislation recently to expand the scope of who could provide personal care services for individuals who have been deemed both financially and clinically eligible for purposes of receiving long-term care in a community-based setting, particularly up in the rural areas where there is not a sufficient workforce to meet the demand for those individuals who have been found eligible. That this builds on what we've done in past sessions where we've opened it up to allowing family members who are, qualified to doing these kind of services to provide for those individuals who are eligible. So that's already an existing law. So this expands on that to include also guardians and those who've been court appointed with powers of attorneys. And you'll see those changes represented in sections 3 and 4 of the legislation, which takes you from page 1, line 19 through page 2, line 20 of the bill before you. So, Chairman, any questions for Attorney Clark or myself?
Any questions so far?
No?
So far, so good.
All right, thank you. That takes us now to page 2, line 21 through page 3, line 4. These sections...
excuse me, Representative Weber?
I'm sorry, I'm a little slow on the uptake here. Would you remind me, because it's a little counterintuitive as I look at the language, I know that's because I don't have the rest of the statute in front of me, but if you could just explain it to me quickly. The first part on lines 19 through 20 through 30 and following says personal care service provider and who they are and who they're not, and the legally responsible relative is accepted out there. But I'm remembering that we put in at one point the fact that we recognized that responsible relatives are providing an enormous amount of care and perhaps they ought to be reimbursed by it. So it takes them out all the way up to line 5, and then so we're just saying that's not a personal care services provider, but we're allowing them to earn anyway under Section 4. Is that how it works?
Yes, that's correct. So
Okay.
by default, they would not be included, but we have ways to authorize them and when they're needed, yes.
And you wanted specifically to keep those separate, is that correct?
Right, so we're also adding the process to authorize guardians and powers of attorney.
Okay, thank you. Appreciate it.
Okay, go ahead. Thank you.
And Chair McDonald, thank you. That now brings us to the next two related sections, which are sections 5 and 6 of the bill found on page 2, line 21 through page 3, line 24. And this also relates to long-term care. And as you know, individuals who are in settings, either assisted living or nursing facilities, they are allowed a small amount of money per month for personal care items, such as things for toothbrushes and things like that for their care. So what this section does is to ensure that that money is not to be used for other things, such as providing for room and board. We have discussed this with the provider community, and they have been universally supportive of this particular provision. And I didn't know if you've had any questions. I know that Attorney Clark might want to add on to Section 6 of the bill what that piece of the bill does. Also, as we work through the process in advance of the hearing in the Senate, we also work with New Hampshire legal assistance and thoughtfully work through some of the issues relative to third-party payees.
So Section 6 of the bill adds a requirement to residential care facility residency agreements that they cannot require third parties to pay for the residential care facility service other than for add-ons like a private room or cable television.
I thought that there was already a requirement that a certain amount of money be put into a discretionary fund for a nursing home patient. That wasn't the case prior to this, or?
There was the piece that is supposed to be protected within the trust, but apparently that's not the case. This shores up the issues. Okay, you understand the question, then go ahead and respond.
I do. Could you restate the question?
Sure.
Right.
No, my mother was in a nursing home, and they had told me years ago when she was there that they were required to put a certain amount of money aside for personal needs, like sometimes they'd take them out to riding around Christmas lights or whatever, or they'd stop for an ice cream or something, and just miscellaneous personal things, and I thought that was already a requirement, but it isn't actually, or?
So there is a provision, and your memory is spot on. There is a provision in state law that requires the facility that's holding the individual, like for even at New Hampshire Hospital, we have similar trust funds that are set up for personal care allowances. So there is that in place. However, invading that trust for these purposes need to be clarified in state law, because apparently there have been some instances where those funds have been sought for purposes of somewhat reimbursement for these room and board items. So,
Okay, all right, thank you. Any other questions?
pays off.
Go ahead, continue, please.
And that now takes us up to Section 7. I'd like to invite up at this time Attorney Robert F. Berry Jr. to join me. He is the general counsel for our department's division for Medicaid services. He works with Henry Lipman, so it means he's the brain trust and a very bright man, very bright attorney. And the next section of the bill that we're here before you is Section 7, found on page 3, lines 15 through 13. This is one that we've been actually identifying for a few years now for trying to address, and it's meant to be business friendly. So we have this thing called the Nursing Facility Quality Assessment. And those assessments are used as part of our rates that we provide around certain long-term care matters. So what this bill does is it says to the provider, to the nursing facility who's having to report to the Department of Health and Human Services and also to Revenue Administration who receives these fees, that you don't have to report to us at HHS. We're trying to take one unnecessary step away for them because we get that information directly from the Department of Revenue Administration as part of the process. So with that, it's meant to be business friendly, and it's an item that we've been looking to take care of for a few years now. And I'd like to turn it over to Attorney Berry if he has any other thoughts.
Nothing more to add other than it just really is meant to eliminate duplicative processes and ensure some efficiency among paperwork that's moving between various agencies and the nursing facility industry.
Okay, thank you. Representative Shapiro.
Thank you, Mr. Chairman. I did not catch where that is in the bill.
Okay, thank you very much. Section 7 is found on page 3, lines 5 through 13.
Okay, thank you.
Other questions? Representative Merchant.
Thank you, Mr. Chair, and thank you for taking the question. Out of curiosity, why would apple cider not be considered a fruit juice to begin with?
And
Apple
that will
cider
be the
fruit.
next section that we'll be addressing.
Okay, thank you.
Representative Nagel.
Thank you, Mr. Chair. Thanks for taking my, I'm just curious why you would have had to report to two different entities in the beginning, why that was made.
So the way that the MQIP payment used to be calculated, which is Medicaid Quality Incentive, and I forget if the P stands for payment or program, so forgive me for that. But what would happen was the department would originally get the information and use that to calculate the MQIP payment. CMS has subsequently said that we can't do that. We need it based on actual monies received, which we get from DRA subsequent to that. So this makes the form duplicative.
Other questions? Okay, thank you.
And Chairman McDonald, that now takes us to sections 8 and 9 of the bill. I'd like to invite up Ms. Colleen Smith. She's an administrator with the Department's Division of Public Health Services under Food Protection. And we are here today now on sections 8 and 9 of the bill, found on page 3, lines 14 through 32. And that gets us to Representative Merchant's question regarding the change to apple cider. And from a food protection service, we have the best person to answer the question here, because you'll see that we deleted other types of fruit juices. So we needed to get more clarity about what was actually being required to getting a license under the water bottling and juices item. So I will turn it over to Ms. Smith if she has anything else to add.
Good morning. Thank you for allowing me to speak to this bill. The Beverage and Bottled Water Program, it primarily regulates wholesalers of beverages and bottled water in the state. There are a few exceptions to that, milk products, because they're regulated under the Dairy Sanitation Program within the department. But there was also a part of the statute that allowed someone that's making a fruit juice or bottled water direct to consumer to not have a license. So we're amending that. So if you are making a fruit juice or bottled water, you would be required to have a license, but with the exception of 100% apple cider. So this would allow apple orchards that are pressing cider exclusively for distribution direct to consumer to not have our license, as has been the case in the past. The other substantial change is that there was also a provision that if someone was bottling a beverage, regardless, and this would be like a lemonade, if it's a grocery store bottling lemonade, they would require this beverage license, plus they could also hold a regular retail food license. So this would eliminate that double licensing. So if they were regulated under the retail food program, they could just have the one license. So and it will have minimal fiscal impact, but certainly the industry it's streamlining regulation over the industry, not having two regulatory inspectors oversee the same operation essentially.
And if I could just restate at a very high level, because Ms. Smith is very knowledgeable in her area. What is happening here in the state, there are what we call self-inspecting towns, like Concord and some of the larger towns, and then there are ones that fall under the oversight of the department. As it currently exists, if you have a restaurant, for example, that you sell bottled water, and you have a license to under our food protection, what this bill would do is say you don't also have to have a second license for bottled water. That's what this does. It's business friendly, and it's meant to, there is a modicum of small loss of some fees to the state of New Hampshire as a result of it. But we think it's a positive because we're covering for that entity based upon that one license, as opposed to requiring a second duplicative license.
Okay, thank you. Representative Merchant.
Thank you, Mr. Chair, and also thank you for taking the question, and sorry for jumping the gun. My apologies. In regards to, I'm being nitpicky here, but if I read this the way it's written, if I have a lemonade stand, do I have to have a license?
If you have
A lemonade stand, do I have to have a license because it's a fruit concentrate?
because if it wouldn't be under this program, it would, if it met the criteria of a retail food license, because you're selling direct to consumer, you wouldn't have, this program is mainly wholesaling of beverages. It wouldn't, if your lemonade stand met the criteria for a retail food license, then it would be under that program.
Thank you.
Other questions? Okay. Go ahead.
And Chairman McDonald, thank you very much, Ms. Smith. I'd like to invite up at this time Attorney Francesca Hennessy. And the next section we're going to be covering is section 10 of the bill, and that is found on page 3, lines 33 through page 4, lines 5. And for those of you who served on the committee last session, you'll recall that our agency came before you to identify that under a program, and it's actually two separate programs, but they serve a very similar purpose. One is called the MEAD program, and I know if Chairman over across the hall made a joke about it being a beverage, but in this case, it actually stands for Medicaid for Employed Adults with Disabilities, and it makes individuals who have certain needs for accommodations much more attractive from an employment standpoint by an employer, because they can, subject to some income eligibility and also clinical eligibility, can receive Medicaid. So it does help offset the cost for employer relative to medical coverage. So that's the bigger program that's out there. So this isn't about anything about the program other than the fact that last session we came before this group to identify that the premiums paid by the individuals who participate in these programs, actually our cost of trying to recover those fees was close to being a wash in terms of an impact to the state. So it made sense at that point that this is such an important program to go ahead and eliminate the premium fees as it relates to the MEAD program. The MOAD program, M-O-A-D, is for Medicaid for older adults with disabilities. It was recently passed within about the past 5 or 6 years, identifying that as we're having an aging population, the MEAD program covers from 18 to 64 years. But the thought would be we have folks that are working well past 65 and folks who have challenges. And so they created the Medicaid for the older adults with disabilities. And also that program, likewise, the premiums were eliminated by this body and signed into law by the governor last year. What this does is additional cleanup. With all thoughtful legislation, you always seem to find when you're doing your gardening that there's other provisions that touch upon that. So we just need to go through that and make those adjustments to remove the outdated references to either premiums or other items that this group, that the legislature already took action on. So I don't know if you have questions for myself or Attorney Hennessy.
Representative Shapiro.
Thank you, Mr. Chairman, and thank you for taking this question. If I understand the MEAD program correctly, and I'm not sure I do, it's a program that allows people who meet certain conditions, who are disabled, to continue to receive Medicaid after they would have otherwise been financially ineligible because they've started working. So I'm very interested in this because I think it's a real problem. That in some cases people don't have the incentive to work more or get a higher paid job because they're going to lose health insurance, and so they're going to lose. Overall, it's going to be a losing proposition. So my question is, how long can someone stay on the MEAD program once they've gone past financial eligibility? And also, I know this is not relative to the bill itself, but also how successful is it in terms of encouraging people who are disabled to get jobs, work, and be more ambitious in that area of their life?
Yeah. I mean, what I will say to your question is this makes it much easier for people to obtain this program because there are no premiums anymore. That was done last session. This is simply a cleanup to take that out of the rest of the bill. I don't know of how long a person can stay on. I can certainly get back to you on that. I can also consult with more of our policy people in Medicaid to see if they have measurables on the success of the program. That's a really good question. I just don't know this at this time.
Okay, I'd appreciate anything I could get on that.
I'll write down your name so I can get back to you.
Representative Weber, did you have a question?
Yes, thank you, Mr. Chairman, and thank you for taking my question. I'm just making sure that this is only about Section 10, is that right? And we're going to deal with Section 11 differently, or is Section 11 included in this particular?
Yeah, my apologies if I did not make it clear. We're just right now on Section 10 of the bill.
Okay, thank you.
It's separate and distinct heading into Section 11.
I'm sure you did, but I was writing something else, so thank you.
Any other questions? Okay, thank you.
And that takes us to Section 11 of the bill. And as it relates Section 11 of the bill. And so I'm going to turn this over to Attorney Hennessy to give you the overview. But okay, well, let me just slow up a bit. Okay, here we go. These sections of laws that we're going to touch upon, both sections 10 and also, I'd rather strike that 11 and 12, do touch upon our Supplemental Nutrition Assistance Program. And so working along with the New Hampshire Legal Assistance, we thoughtfully did amend the bill in the Senate to reflect that no longer is a program referred to as food stamps. That's just a vestige of the fact that this statute hasn't been amended in large measure since the mid-90s. And so we're here today essentially on both of those two sections to do something very simple, which is to align under state law, the federal law as it relates to overpayments. In other words, if an agency overpays the amount of, that you're to receive for the Supplemental Nutrition Program, there is a process already in place in law, but we just want to make sure that our state law is aligned with the federal law. It's one of the requirements that we have with what they call the Federal Nutrition Services Program. FNS is another acronym that's out there that you might be hearing us talking about. I know your chair is very familiar with all the subject matter and perhaps would do a much better job than myself in terms of giving into the background, but that's essentially what we're trying to do, is to have it tie in with the provisions of the federal law as it relates to overpayment in Section 11 and in Section 12 of the bill. It's in terms of disregards if we have individuals who have been deemed not to do the right things, and 3 times, I guess, is not the charm when you're not doing the right things, that the disqualification pieces of this also play in. So that gets into the area of safeguarding, valuable taxpayer dollars as it relates to disqualifications. And so we're aligning also with federal law. Because one of the best practices is to make a reference to the federal citations or whatever, it's a great practice to doing that in law. The problem with that is you can't see what those CFRs are. So certainly I'm looking to the venerable members of your committee who might be attorneys as well to also supplement what we are providing here. But we have gone through the process to making sure with great detail that the provisions we're referring to here do refer back to the correct federal citations and law. So with that, I'd like to turn it over to Attorney Hennessy.
Good morning.
Good morning.
So in terms of section 11 and 12, starting with section 11, this was a provision that we identified in going over our law in terms of cleaning up what our practice is and aligning that with the law. The Food and Nutrition Services, our federal oversight agency, has approved a particular claims management plan for us. And in that plan, they have approved that for any errors the department makes, we are required under federal law to collect back that money. However, they have allowed us to simply make the statement that if it's not more than $450, please don't go after it. And so we continue to do that. We've always done that. The second section, they've never approved, and we don't know that it is approvable by FNS, so we're taking out the hard to measure recipient's income being less than or equal to 2 times the federal poverty level. It brought up a lot of questions for us, such as at what point in their life are they under this federal poverty level? It was a hard thing to quantify, in addition to it never being approved by the federal government. The second section, section 12, this is all federal law. So under 7 CFR section 273.16, these are the current disqualification penalties. And John's right, 3 times is the charm. If you are overpaid, as Representative McDonald knows, after 3 times, and you did that on purpose, you are now no longer eligible for food stamps, and that has never changed. What has changed is that they have upped the disqualification penalties, and we're simply aligning with that. Thank you.
I think it was the back in '96 when, as far back as that, but that was changed, right, to 12. And I think any claims prior to '96 was 6, 12, and permanent. Then it went up after the '96 Welfare Reform Act.
Yeah, thank you. I wasn't exactly sure, but it it is long overdue for being updated. So thank you.
And I remember the new statute books we get every year when I was at the department, they still said 6, 12 and permanent, so.
And it may confuse judges where these cases are going before. Yes, thank you.
Representative Shapiro.
Thank you, Mr. Chairman. So I don't have it in front of me. RSA 167-17-B, is that the section in state statute that spells out
It is.
the violation and the penalty?
Yes.
And the violation is accepting more SNAP benefits than you're supposed to be accepting?
Yes, if you have been receiving SNAP benefits and you are convicted under 167-17B, your first violation, you will be disqualified for, in the updated law, 12 months. Your second time you do that, it's 24 months. And after that, it's permanently. So you do need a conviction. So it would have to be intentional. Intentional violation.
So that assumes it's something that the consumer did to get more benefits than they should have, that it wasn't just an error on the part of the state.
Yes, thank you. So it's an important clarification between the two statutes. The first one I mentioned was just errors on behalf of the department. This section is intentional violations on the part of the recipient.
Thank you.
And there's also client error claims that can be collected still, right? But no,
Yes,
no problem.
absolutely.
Representative Weber, did you have a question?
It's been clarified, thank you.
Okay. Any other questions? Thank you.
And Chairman McDonald, that takes us to the final coupling of sections, and I want to invite up at this time Ms. Danielle Hernandez. She is an administrator with the department's Division for Public Health Services, and she is here in her capacity as administrator with our state Office of Rural Health. She does incredible work, particularly for underserved regions within the state, and this is a request from the department to take a reporting requirement that we currently have from an annual basis all the way to making it a 3-year reporting requirement. And this comes with the endorsement of the underlying commission that actually looks at primary care and workforce issues, and at their January 25th meeting, if that's a Thursday, which I believe it is, they actually formally voted and approved these sections of the bill, recognizing the importance of the work, but that the frequency of the information, certainly based upon the good works that are done, that a 3-year cycle is helpful. There are additional reporting requirements that the State Office of Rural Health has to make on an annual basis in addition to this. So I would just turn it over to Ms. Hernandez, who does an amazing job in her capacity as administrator with our State Office of Rural Health.
Thank you. What we're asking is really just to separate two fundamentally different reporting requirements. When legislation passed on health workforce data collection, what it did was required an annual report to be incorporated into this health disparities report. And so really what we want to do is, because they're so different, we want to separate them out so that it makes it easier for stakeholders like yourselves to find the information you're really looking for, instead of, scouring through 50 plus page report to find, health disparities information by geography or primary care supply and data collection efforts work. And also what this would do is give consideration to limited staff resources for multiple offices. This takes the better part of about half a year to put together, to coordinate, to compile statistics for. And it would also allow for consistent reporting of measures and current estimates, where we don't currently have that because the data isn't collected annually or analyzed by the respective office annually. So often the data in the annual reports for the health status of rural residents will be unchanged or even excluded. So we know that changes in health status are incremental, right? They very rarely happen year to year. So we know that we wouldn't be limiting our, knowledge or understanding of health disparities in the state if we changed it to a 3-year reporting cycle. the health statistics that we have seen changed, it's only because of the change of a survey tool or, the analysis methodology. It's not because there are actual changes in the health between populations in the state.
And just for a point of reference, that these changes for the 3-year reporting requirement are found in sections 13 and 14 of the legislation found on page 4, line 25 through page 5, line 9. And if there's no questions on this section, that takes us to the last two sections of the bill that are coupled together, which are sections 15 and 16. This was made at three.
Representative Nagel has a question.
I'm sorry.
I'm trying.
Thank you, Mr. Chairman. Yeah, nice try. I thank you. I just how do I access this data, the report?
Yes, so the report is actually published on the DHHS website on the Rural Health and Primary Care page. We also present the report to the HHS Oversight Committee, which is scheduled for the end of the month, of this month. But the information is always available. And I think you will find, if you do locate that report, I can certainly send it over to you as well, that it is difficult to be able to find, the information, depending, again, are you looking for primary supply statistics? Are you looking for health workforce efforts? Or are you looking for health disparities information? It is sort of hard to locate the information in the report because it's all glommed together.
Oh, okay. All right, thank you.
Representative Palazzo.
Thank you, Mr. Chairman, and thank you for taking my question. Maybe I'm missing something, but help me understand this switch from annual report to every third year, because sometimes things happen fast and we want to know what's going on. Like 3 years ago, maybe there was no COVID pandemic, so if we would go and wait for 3 years until the report, we would miss some important information.
So I want to clarify that one of the reports on for the health workforce data collection, and that's the primary care supply piece, that of course is important to track the trends of annually. That would still be required to be reported on annually. So that's the intent here. The initial report that has been a statutory requirement since 2009. On health disparities by geography, basically health status of rural residents, would change to every 3 years. So it's really just separating out that report. The one that we really do want to have our eyes on and report on annually is going to stay as an annual submission. The other is going to be every 3 years because we found that since reporting, there really hasn't been any incremental changes, and there are very slight incremental changes. And when that does happen, it spans really 5 years or so. And we know we wouldn't be losing any information, limiting any information that's necessary for state policy and work.
Thank you. Other questions? Okay, thank you.
And Ms. Rogers, who I was going to call up next, had to leave for another hearing in the Senate HHS, but we are loyal to this committee, and Ms. Hernandez is going to stick with me because it also involves public health. The sections 15 and 16 of the bill were made as an accommodation, a request by Senator Prentice, who serves on and if we can look at the title together, because it's a very long title, it is the Commission we'll start right over here. Here we go. The Commission to study the delivery of public health services in New Hampshire through regional public health networks. And all this is doing is extending the sunset provision for this year for an additional year to allow them to do their important work. And I didn't know if Ms. Hernandez has any underlying subject matter knowledge as it relates to this, but otherwise we were fine with this bill being used as a vehicle for those two sections. And Chairman McDonald, if there are no questions, that completes the department's presentation on Senate Bill 127.
Okay, I see no questions, so.
I want to thank you and all your committee members for your patience in us getting through otherwise what would have been 8 different legislative hearings. So we appreciate that, and thank you very much for your thoughtfulness and your consideration of this bill. Thank you.
Thank you, and thank you all for coming today. Okay, also signed up to speak is Representative Jess Edwards from Rockingham 31.
Thank you, Mr. Chair, committee members. I'm Representative Jess Edwards, representing Rockingham District 31. That's Auburn, Candia, Chester, and Deerfield. Since redistricting, I have to keep practicing that. That's why I say it. But I'm also here today fulfilling part of my duties as the chairman of Division 3. I'm looking at House Bill or Senate Bill 127 FN, and I noticed there are some things in here that might have been HB2 kind of items or proposals either from the governor or something brought to us during the House Bill 2 phase that did not come over to us. So I wanted to just comment on it. First, I'd say that most of the experienced representatives, when you first saw this bill, I hope you thought, as I did, oh no, it's a Christmas tree. There's the problem with Christmas tree bills. When you identify a bunch of items in one bill, it really gets to be hard to draw a focus and get the right witnesses to talk about each specific item. Things go kind of quickly, and it's just a process that makes me nervous that we might overlook something. So specifically on page 1 of the bill, lines 3 through 18, there's a policy issue here where we want to take we want to establish fees for the opiate treatment programs, and we want to put those into dedicated funds, and we don't want them to be deposited into the general fund. And I would just tell you that as somebody who looks at the budget a lot, these kinds of things reduce the legislative authority that I think we have under our Constitution to pay attention to how money is getting spent. So as a general principle, putting money, taking it out of the general fund and putting it into a dedicated fund, I think is a policy issue that I don't particularly like, and there needs to be a high threshold before we do that kind of thing of why that's really necessary. And then I think there may be sort of some missing math here. If you look at page 5, or excuse me, line 5 into line 6, it says, if the provider had no clients in the previous calendar year, then the fee shall be $1,000. Okay, so what if they only had one patient? Then according to that section, they would have to pay $8. So I think what this is attempting to do is to say the minimum amount that any provider must pay is at least $1,000 plus $8 per patient. And so that's a policy question of whether or not it makes sense, but I just think we missed part of the math there. Otherwise, it wouldn't make any sense. If I were a provider and I didn't have any patients, in December I would go pay somebody $500 to be my patient, then I'd only have to pay an $8 fee, and I'd still make a lot of money. So it's just not good math. Then I don't know this to be true, and if this comes over to Division 3, I'll be asking questions about this on pages 4, lines 25 down, talking about reports for the Office of Rural Health. I ask the question, is this redundant? And I wonder if it's redundant because we have a dedicated office called Health Equity. Health Equity has 7 FTEs in it. I think we appropriated like $2.4 million for it. And one of their roles is to take a look overall at the distribution of clinical care around the state and to make recommendations if there are shortages, particularly if there are problems that we can associate with it. We have all kinds of groups running around right now trying to deal with our workforce issues. So I would just say that this section 13 and maybe 14, I'd have to look at it a little bit more, may be redundant and perhaps there were more questions still to be asked to make sure that we're not duplicating efforts. So that's it.
Okay, thank you. Questions for Representative Edwards? Representative Shapiro. Oh, the representative, that Representative Edwards raised, you mean, or? Yeah. Sure.
Specifically, I was wondering about Representative Edwards catching the math issue, which makes sense to me. So,
Attorney Williams, can you help us with this, or?
Yes, there are two things you don't do on a legislation like this. You don't say a word that I'm not going to say, although some of our staff did use the word clean up, I think. And the other one is definitely making sure you contact all the right people in advance and certainly recognizing Representative Edwards' leadership. He's to be applauded for the work that he's done on behalf of New Hampshire citizens and also here at the legislature. With that said, what I want to bring to your attention on sections 1 and 2 of the bill, this body, and I think it was part of my original testimony to the committee, was actually passed last session as part of HB 1661. Originally, it was in the department requested bill, which was Senate Bill 430, but that bill got held up in the process, and then eventually through the committee conference process, it was added in advance of the process to HB 1661. So in terms of an articulation of the policy, both the Senate and the House has already acted on the underlying policy relative to creating this fund for the opioid treatment programs. So that law is already on the books. All what was being attempted to be done with this is reflected in the fiscal analysis on the bill was to clean up an incorrect statutory reference. Originally, it made reference back to the fund itself, and the fees that are being collected are not in that same statute. They're in the Controlled Drug Act, and that is where those fees are being collected. So again, it was correcting a incorrect cross-reference to where those fees were located, but the underlying policy was passed by the legislature this past session in HB 1661. With that, I always have to recognize that new eyes can look and have further conversations, but it is something that we weren't trying to do anything different than wasn't already passed by the legislature last year.
Okay. Thank you. Representative Weber.
So if I'm hearing you correctly, that explains the origin of the dedicated fund, whether or not we agree with it. But the question about the math is still unresolved. And I was wondering if anybody, I think Representative Shapiro also asked this, if anybody could speak to the issue of if you have one client, you pay $8, and if you have 0 clients, you pay $1,000. And I'm actually wondering why, if you have no clients for an entire year, you're paying a fee of $1,000 in any case. And I think clarification would be very helpful on that.
Yeah, so just so folks understand that the fee structure here has been placed in statute and I believe also adopted through administrative rules. So what you're talking about is an existing law. This is not a new provision of law in terms of the funding mix. Should that be re-examined again? I leave that question open for others to look at. But what I could represent to the committee is that the sums of money we're looking at, our total fees collected range anywhere between the upper $30,000 range annually to around $40,000 around ballparking, but I can get you specific and also Representative Edwards specific fees from our financial managers around that. So we're not looking at a large sum of money, but it is important to support the important efforts around opioid treatment prevention. And the identification of any issues are in existing law. It's not anything we're attempting to do with this legislation.
Right.
Follow up?
I get that. I would be more, I would be happier in my mind if it was explained to us with more detail so we understand what we're looking at.
Understood.
Because I agree on the words that we have here do imply an oddity.
And I certainly can get back to the committee with a further explanation on the number of programs that we actually oversee, how the breakdown works in terms of each individual program and the payments that they make to us. And once you get that information, that data, it may make more sense once you see it. I can just give you the derivative, which is the cumulative fees that we do see from these programs range anywhere between the upper $30,000 to around $40,000 in 2022. So our snapshot looking at about a 3-year perspective retroactively, but certainly we'll follow up with the committee and also with Representative Edwards with more detail around that.
Okay. Representative Nagel and then Representative Seth King.
I kind of had my hand halfway up, but I do want to ask the question. This is really more of a policy issue, but I'm like totally blurry-eyed now from reviewing a lot of policy statements about the 10-year mental health program, the drug abuse, all the governor's task forces on these things. And one of the statements that's made over and over and over again is about our deficiency in terms of medication-assisted therapies, access to methadone treatments and things like that. And I'm really struggling with the concept of actually having these groups pay us money when I think we are desperate and we should be paying other people money to subsidizing them to provide the service. So I'm lost why we're even charging them at all. That's a statement, that's policy statement, that's probably, I know is not reflected in this bill, but since it was brought up, I thought I should bring it up.
Yeah, and Chairman, if I can just address briefly, Representative Nagel, those have already been articulated by the legislature. The legislature, you, this body, and the Senate, that body, and the governor, whoever signed off, established that policy prior to us coming here today on the bill.
I know.
Certainly, I think getting the data and understanding is going to be helpful. We certainly think supporting those medication and treatment programs are very, very important as well. And we also think that supporting our efforts in our agency, which was already passed last session in HB 1661, to allow that modicum to support our efforts to supporting those programs would be particularly helpful. And all we're trying to do is correct the cross-reference to the correct funding mechanism in this legislation.
Representative Seth King.
Thank you, Mr. Chairman. I hope I'm not speaking out of line here, but I think this makes perfect sense to me, the $1,000. Every provider at some point wasn't a provider, and this is basically just a startup fee. It's like, imagine joining a gym. Your startup fee might be $300 new, and then it's $30 a month after that. But if you've been a member of the gym for the last 20 years, you're just paying $30 a month. You don't need to you don't ever have to pay that. You were already kind of grandfathered in. So the $1,000 is just a startup fee. So that's how I understand it. Thank you.
Thank you. Representative Shapiro.
Thank you, Mr. Chairman. In regard to Representative Edwards' last point about page 4, line 27, the report on health equity being changed to every 3 years. Is that a redundancy or is that a requirement of receiving some kind of federal funds? And it could still be a redundancy, even if it is a requirement.
If I understood Representative Edwards' observations correctly, and I'm going to look back at him and he can shake his head yes or no as I'm speaking, that would be helpful, that in the presentation by the department before Division III House Finance, we did agency presentations that broke it down to particular either offices or bureaus within our agency. One of the briefings would have likely involved our Office of Health Equity. And I think what Representative Edwards has identified is an overlap between the mission, and I don't want to be too broad, the mission of that entity within the department, and then branching over to the work that Ms. Hernandez and her folks do under the State Office of Rural Health. As an agency, we are always responsive to looking at appropriate alignments, and I'm not in a position to articulating anything because I'm not at that level, Representative Edwards, to make that happen. Others could, perhaps. But for example, in the area of homelessness and housing services, we recently transitioned that bureau that was under our Division for Economic and Housing Stability, which is now called the Division of Economic Stability, because we moved the housing from that program. And that program was around other types of assistance and supports that we provide to people like the SNAP benefits and other kind of assistance that we provide. We moved that program under homelessness and housing to the Division for Behavioral Health. And we did that because the population being served in behavioral health better aligned with the needs for housing. Because you can't fully systemically treat people unless during the process they have a place to live when they're going out the door. You got to have something to address coming in the door and something coming out the door. So I do think that there is a receptiveness to looking at alignment issues, and I think that that's what Representative Edwards on a much higher level. We were just asking for a 1 year to 3 year change and not a complete realignment of the department, but I do think I understood what your observations were. Close.
It's a question about potential redundancy and then aligning the missions and the work so we're not funding the same thing twice.
Thank you. Other questions?
And if Ms. Hernandez, she's actually going to give you the correct answer to Representative Edwards' question. And I didn't know if Representative Edwards even wanted to be invited. I'm happy to see the chair. All right.
I just wanted to expound on that, that yes, the State Office of Rural Health under Rural Health and Primary Care in the state is established as the SOAR in statute since 2009. We're actually the SOAR is exclusively funded by HRSA, by a grant under HRSA. So while this report is a statutory
What does HRSA stand for?
Oh, the Health Services and Health Resources and Services Administration, excuse me. So although this is a statutory requirement to provide this report, it's just one of several activities that is conducted under federal funding, not by the state.
Thank you. Other questions? Seeing no other questions? Okay, thank you.
Thank you.
I have no one else signed up to testify on Senate Bill 127. Does anyone else wish to testify? Seeing no one else, I am going to close the public hearing on Senate Bill 127. Thank you all for your testimony. And I am going to open the public hearing on Senate Bill 200 and recognize the prime sponsor, who is Senator Rosenwald.
Thank you, Mr. Chairman. For the record, I'm Cindy Rosenwald. I represent Senate District 13, which is most of Nashua. And I'm very pleased to introduce Senate Bill 200, which will open up another means to make certain vaccines more conveniently accessible and at lower cost to consumers. It does so by allowing optometrists to administer influenza, COVID, and shingles vaccines to adults. Optometrists are doctoral level healthcare providers who are highly experienced in sterile techniques. They are represented here today, and they can explain why this bill is a good idea from their perspective. I would just say that we have allowed people to get vaccines in pharmacies from a variety of different licensing levels of pharmacy employees for 15 years. It's worked really well. It's less expensive for people, and it's very, very convenient. So from my perspective, consumers will save money on these 3 vaccines because just as at a pharmacy, they won't need to pay a separate copay if they're already at the optometrist's office. So if they went to their physician to get these vaccines, they would have to pay a copay. And these 3 vaccines, I think, make a lot of sense. Influenza and COVID are recommended for broad groups of adults, and shingles is recommended for people over 50. Also, shingles is a disease that can have devastating effects on vision. So it makes sense to me for optometrists to administer shingles vaccines. We thought we had allowed optometrists to administer COVID vaccines during the public health emergency, but it turns out we will need to make a statutory change. I hope the committee will look favorably on this bill, and I'm happy to answer questions.
Thank you, Senator. Representative Weber.
Thank you, Mr. Chairman, and welcome back, Senator.
Yeah.
My question is about record keeping. People have gotten used to medical records being kept at physician offices or primary care provider offices. They're also now used to record keeping at pharmacies. An initial glance at that is that although the shingles connection seems pretty intuitive to me, the other two are kind of counterintuitive. Could you talk a little bit about record keeping and how people, as the places that you can get vaccinated become more and more diffuse, how people appropriately access their records to know when they need to get shots and when they're overdue or when they shouldn't be getting shots?
Well, if you look at the bill, starting on page 1 of the bill, line 29, this would require the optometrist to check the vaccine registry ahead of time and then record the vaccine administration in the registry unless the individual opts out. But if your question is, how does just random me know that I need a shingles vaccine, I think it's helpful when a provider says, have you had a shingles vaccine? And I probably would say, I can't remember. But they would be able to check the vaccine registry unless I had opted out. They would be able to say, oh, you've already had it, you're all set. Or you haven't had it, yeah, you're over 50. You should have it because shingles can make you go blind.
And I just thank you for the question and apologize for not having done my homework a little better.
Not necessary. Representative Shapiro.
Thank you, Mr. Chairman, and thank you for taking this question. Would you envision, maybe this would be better directed towards optometrists, but would you envision that this being a kind of a sideline for optometrists where there would be advertising that these vaccines were available at optometrist's office? Or do you envision it more as in the course of getting your eyes checked that you would be asked about and reminded that these are good things to do and that they're available at that very office?
That's a really interesting question. Personally, I think not that many optometrists would do it because there's record keeping. For COVID vaccines anyway, you need that super cold storage. I don't know that very many of them would make a business decision that what they would get reimbursed was worth the time and expense of doing it. So I think maybe some very large practices might decide, and I think you're going to hear from one of them after me, that this is a service, that if they put eye drops in somebody's eye and then the patient is sitting around for 15 or 20 minutes, that it would be an opportunity while they're in the office to have that conversation and then do this other service. I don't think it would be broadly adopted. I might be wrong, but just looking at that, the effort and the expense that goes into stocking these things and the paperwork, I'd be surprised if that many practices decided it was worth it.
We do have someone signed up from the New Hampshire Optometric Association who will be testifying, so. But sure, go ahead.
I would just, as someone who just a week ago or so got my shingles vaccine.
You're so young.
Thank you. And having put it off for many, many years, so I'm not that young, and in part that it just became free, but also that they didn't have it at my doctor's office for whatever reason. So I put it off for decades, I guess. And had I been someplace where someone said, "Oh, if you want that, we can just give it to you," I probably would have done it a long time ago, and it would have been safer.
Well, I'm glad you didn't get shingles in the meantime.
Other questions? Yes, Representative Kane.
Thank you, Mr. Chairman. Thank you, Senator, for taking questions. I don't have the full RSA that's being amended in front of me. I apologize, but I'm reading this here, and I see that they can currently apply topicals and oral medications. Are there currently any vaccines that optometrists can currently, use subcutaneous injections for? Or is this going to be opening it up to a whole new section of things that they can do? Thank you.
I think probably one of the optometrists could better answer that question. I'm going to say I think they can't, but they'll be able to give you a better response.
Other questions? Representative Nagel.
Thank you, Mr. Chairman. Thank you, Senator. To me, there's three important questions involved in this bill. The first is, and you don't need to answer, the third one's the one that's most important, but like why? Why are we doing this? Secondly, are they qualified? But thirdly, which is most important to me from a public health point of view, obviously access is important. I think we did demonstrate we were pretty accessible to a broad pandemic. Is this absolutely necessary to increase accessibility? And is this the best way to do that?
I don't know that it's absolutely necessary. I think you'll hear from some of these optometrists that they are a provider that somebody sees even when, I hate to say this to you, they don't go see their physician. So sometimes they're the only provider that someone sees. And let me just say that in my own family, my 53-year-old nephew hadn't seen a doctor in 10 or 15 years, but does regularly see the optometrist because his vision needs change. So I know already one person who only was seeing an optometrist. Let me also just try to answer your other question about are they capable, I guess. If you look at the statute that allows pharmacies to give a way bigger range of vaccines, we allow pharmacy technicians, pharmacy interns, not just pharmacists. So not just the doctoral level person, but people under their supervision who I think have a lot less education and experience than a doctoral level optometrist who is well versed in sterile technique. So I think they're capable, but
Wonderful answer.
what do I know?
Thank you.
Thank you. Other questions? Yes, Representative Palazzo.
Thank you, Mr. Chairman, and thank you for taking my question, Senator. What was the logic to put age limitations in this bill about 18 years old?
So we allow pharmacies and have for 15 years to give a broad range of vaccinations only to adults. When I asked the state's chief medical officer, Dr. Ballard, about the other bill that I think you heard, the RSV vaccine, he said, we want to make sure that children are still getting their vaccinations within their pediatric care settings because there's a lot of other care. and counseling and thought that goes into it. So there's not thinking among the medical establishment of the state that it's a good idea for children. And we have not allowed children to receive vaccines in pharmacies over the 15 years. So this is consistent with that statute, and I personally think it's appropriate.
Representative King.
Thank you, Mr. Chairman, and thank you again for taking another one of my questions. As the crafter of the bill, why did you only include those 3 vaccines? Why not just open it up to everything? Thank you.
Okay, that's a great question. First of all, we don't open it up to everything in pharmacies. And this question has come up because most states do allow pharmacies to administer any vaccine that's authorized by the FDA. We don't. Here's why I think that's appropriate. There are some vaccines that are given to smaller groups of adults based on their specific travel plans or their social habits or their medical history. And so I think if we're going to open up all vaccines, I think it's going to result in some people getting vaccinations that they really don't need, and it's going to add expense, unnecessary expense, to the healthcare system overall, because these vaccines, you might get them without a copay, but there's cost to your health insurer. So I think the limitation is wise. Why these 3? I'm an incremental kind of a gal. And this is a new scope of practice for optometrists. These are 3 vaccines that, as I said, are given to broad groups of people. You don't need to know if the person is traveling to, this part of Panama, not that part of Panama, or whether their sexual habits make them someone who should get a monkeypox vaccine. It's just basically, oh, you're an adult. Have you had your flu shot this year? No. Want it? So that's why I just think it's prudent and fiscally prudent also.
Other questions? Seeing no other questions? Okay,
Thank you so much. I'm sorry I can't stay for the whole.
No, that's fine. Thank you, Senator.
Thank you.
Also signed up to speak is Dr. Angelique Sawyer from the New Hampshire Optometric Association.
Good morning.
Morning.
A special thank you to Senator Rosenwald for her time and for answering all of those questions. I have some thoughts and words I'd like to share, but then I do invite you, if any of those questions were not fully addressed by her or any others, please, I'm happy to answer those. My name is Dr. Angelique Sawyer. I am a New Hampshire native and a practicing doctor of optometry in our rural North Country, with offices in both North Conway and Berlin, New Hampshire. I thank you for the opportunity to speak to you today in support of Senate Bill 200, a bill that seeks to accomplish 2 goals: to authorize doctors of optometry to administer vaccines and to allow doctors of optometry to prescribe medications for the treatment of the lacrimal gland. First, some background. Doctors of optometry do not simply prescribe glasses and contact lenses to correct vision, as was the case well over 50 years ago. Since the 1970s, doctors of optometry have been prescribing medication for the treatment of disease. We are recognized federally by CMS as independent physicians. While our focus is on treatment of the eye and visual system, we understand, assess, and educate our patients on how the entire body impacts their eye health. All day long, I discuss with my patients not only their diabetes, but their rheumatoid arthritis, their thyroid disease, their shingles, and how those conditions impact their eyes and their vision. Next, I'll speak briefly about the lacrimal gland restriction that this bill would address. Since 1993, doctors of optometry in the state of New Hampshire have been able to prescribe oral medications for the treatment of all anterior structures of the eye, with the exception of the lacrimal gland. The lacrimal gland is located in the upper outer corner of the orbit, produces the watery layer of the tears. If it becomes inflamed and if it's due to an infectious cause, that infection can spread, leading to something that's called orbital cellulitis that can be vision and life-threatening. We are able to treat orbital cellulitis, but we are not currently allowed to treat the dacryoadenitis that then may lead to that. We have for decades, doctors of optometry have been trained in the diagnosis and treatment of lacrimal gland infections by accredited colleges of optometry. And in fact, as I said, we can treat the complications of, but not the precursors to prevent that complication. In these situations, a delay in treatment while referring to an ophthalmologist is critical and unnecessary when we have the training and the ability to treat this before more serious complications develop. The second aspect of this bill is what we've been talking primarily about, is the administering of the vaccinations. During the height of the COVID-19 pandemic, when the governor issued emergency orders to address the immediate need for additional medical trained personnel to administer COVID-19 vaccines, doctors of optometry could not be included because of our outdated statute, which strictly prohibited this. An independent doctorate level healthcare provider was refused from providing this aspect of care, while individuals with far less training were permitted, including medical assistants, licensed nurse practitioners, dental hygienists, and pharmacy technicians. In New Hampshire, if I have a high school diploma or a GED, I can administer vaccines. But if I've gone on to have 4 years of college education and 4 years of doctorate level training in optometry, I'm now restricted from being able to provide that care. This bill is not about doctors of optometry feeling left out during the pandemic, nor is it an opportunity for generating revenue, as some may suggest. This bill is about removing antiquated restrictions in order to allow doctors of optometry to use their training to provide better quality and greater access to care for our patients. We are the eye care, the primary care provider for the eye. We have many patients who are in exam chairs more often than in their primary care provider's office. Access to care is not just about geographic location and travel distances, but also about patient convenience. Patients who may be interested in receiving a vaccine while in a provider's office may not always take the extra steps to make an appointment and travel elsewhere to receive that vaccine. The truth is that most doctors of optometry are not planning to offer vaccines in their offices at this time, but the landscape of healthcare is changing and provider shortages are increasing. Doctors of optometry should not be restricted from providing care that lesser trained individuals are permitted to provide. This bill specifies, just as with all other medical professionals who vaccinate, that doctors of optometry will be required to fulfill the appropriate vaccine-specific requirements for training, administration, safety, reporting, and adverse events. Thank you for your time, for serving our patients and the citizens of New Hampshire. I ask that you please support Senate Bill 200, and I'm happy to answer any questions.
Questions? Yes, Representative Shapiro.
Thank you, Mr. Chairman. I have two questions. One is, why not include the pneumococcal vaccine, which seems like I don't really know anything about vaccines, but it seems like a seasonal vaccine like the flu vaccine. That's my first question. And second question is, how well equipped are not the doctorate level optometrists, but your office is equipped to deal with immediate severe side effects should those occur?
Absolutely. So first, in regards to the vaccines, again, it is similar to what Dr. Rosenwald said, starting incrementally. These are ones that we so frequently and wide population range, and particularly in the case of shingles, that we're seeing the outcomes of it on a frequent basis. We are certainly open to including additional vaccines in the future, just as she indicated, even pharmacy is restricted as to which ones they provide. As for training in the office, we would not have other providers in our office that would be administering the vaccine. That would be done by the doctor of optometry. However, we do train our staff on all emergency situations. We offer CPR training to all of our staff. We have crash kits, not a crash cart, but we have medications throughout the office. We have smelling salts. They're all prepared for if a patient is having syncope, fainting, the proper way to respond to that patient to get them in a safe situation and to have the doctor of optometry immediately available.
Other questions? Representative Murphy.
Thank you, Mr. Chairman. Thank you for taking my question. My question, I guess, in a sense, refers back to Representative Nagel's question is, why now? Right now, I understand that we have about 98% coverage for vaccine access for everybody in the state of New Hampshire within 30 minutes or a 30-minute drive from their home. The pandemic emergency will be lifted in May, but also we were told yesterday that for all intents and purposes, it's over at this point in time. The reason I ask that question is I think sometimes patients get confused as to what vaccines they've had, how many they've had, the various types of vaccinations they have. So my question is, why now? Why wasn't this done and introduced 2 years ago at the peak of the pandemic? And as you may know, that there are multiple vaccines that are given with COVID. There's a bivalent, there was the initial, there's both Moderna, there's Pfizer. And my concern is that in the bill, it says that if a patient basically, when designated by the patient, it's allowed, the primary care is notified of getting a vaccine. So my concern also is that the patient, if they have many avenues to get these vaccines, and they're not sure which ones they got, which one was a bivalent, which one was Moderna versus Pfizer versus J&J, whomever. The record keeping and the accountability to the primary care, I think sometimes can be potentially diluted. And I'm just concerned about them getting vaccines at multiple different sites.
Understandable. We would follow the same reporting guidelines as with pharmacies. We already, probably to an even greater extent, do record sharing with primary care offices. We are very frequently sending reports back and forth when I'm beginning a topical treatment that may interact with somebody's other medications. I'm making sure that their provider knows new medications that are being added to them. I would not treat a patient if I do not have access to registry information or their healthcare records and know whether that is appropriate for them. That is part of the training and part of the indication as to whether we offer these. And there are some optometrists who may choose not to, and there are some optometrists who won't go through the training to be able to do this. But particularly where I'm located, 30 minutes is very far for somebody to get to a provider. Many primary care providers are not available. We have a shortage in our area. We have primary care provider offices that have very long wait lists to get in. And so this is about being able to provide access when we have the patients in front of us. This is about removing a restriction that prevented us from being able to be included even when there was an emergency order. And we can't allow for just an emergency order to address this in the future. If something were to come up, this needs to be fixed at this level so that when things come up, we're prepared to address that.
Follow-up. Thank you. You mentioned that you do offer staff CPR training.
Yes.
Is it mandated?
It is not at the staff level. For optometrists, it is. For doctors of optometry, it is, yes.
It is mandated for you to have CPR?
Yes.
Okay. And how often does a patient come into your office, into an optometrist? Because, again, it's foreign to me. I usually think of the CVS, a pharmacist, the hospital, the primary care. How often does a patient come into an optometrist's office and say, I would like the COVID vaccine or the flu vaccine or the shingles vaccine?
Well, right now, never, because they're not aware that we're not allowed to offer it. We don't advertise that. To the question that was asked earlier, I don't think that is going to be something that we're promoting, hey, come here to get your vaccine. There are places where if people are seeking out their vaccines, that they can have that available to them. If they do learn and this becomes available and something that we can offer and they seek it out to us, absolutely, we would like to be able to provide that. But that's not why we're doing this. We're not doing this because people are knocking down our doors and saying, hey, I want my vaccine, why can't you give it to me? We are trying to add to that access for those patients that are there in front of us. I have many patients that I see every year. I have many patients that I see 3, 4, 5 times a year. I see shingles very frequently, and many of those patients have not been seeing a primary care provider, have not had that opportunity to have that vaccine, and are not thinking, oh, I need to go ask for somebody to provide that. So as part of our primary care service that we're providing to our patients when we're discussing their total eye health, that question comes up. Have you had your shingles vaccine? No. Okay, this is why it's important, and this is some of the complications to your vision that can happen from this. Oh, that's great. Oh, but I have to go somewhere else to get it. Well, I don't have a primary care doctor. The pharmacist sitting in the hallway, somebody that they don't know my history. They don't, this technician does not have the history with me that you have as my eye care provider. But that's not something that we're able to offer you at this time.
Representative Palazzo.
Thank you, Mr. Chairman, and thank you for taking my question. It's two-part. First, I wonder if you, in your practice or as an optometrist you're working with, ever dealt with vaccine adverse reaction or considered it or reported it to vaccine adverse reaction database files. And second part is like, what's my concern that I'm here from other jurisdictions, for example, from optometrists in British Islands, that a very small percentage of people who got COVID vaccines, they have problems with vision, but when we got it to absolute numbers, it's like hundreds of people. So my concern is if optometrists already have some hesitation to consider adverse reaction and reporting, like if somebody is losing vision, you probably want to asking them when was your last vaccination, and now we will with this bill we will have situation when optometrist will be the person who administered the vaccine and the organization profited from them, so then there will be even more hesitation to investigate and report those reactions. So could you comment?
And I'm not quite sure if I followed everything. We would absolutely be held to the same responsibility for reporting adverse events. If I have a patient who has had an adverse event and we determine that they've recently had a vaccine and I am currently on the receiving end of treating an adverse event, I typically work with their primary care provider to address that event and to discuss, the relationship there, and work with that provider to report that event, because we do not currently have access and the ability to do all of that directly. I apologize. Was there another question?
Do you know a single case when optometrist in New Hampshire reported an adverse vaccine reaction ever?
Right. So I would understand that. No, I don't believe that there is a case that has been reported to date. There may be in other states where optometrists are providing vaccines. There has been no increase in malpractice or liability rates in other states where optometrists are providing vaccines. There has been no increase in adverse events in those states.
Representative King.
Thank you, Mr. Chairman. Thank you for taking questions. The sponsor of the bill seemed to be under the belief that very few optometrists really would take advantage of this and offer vaccines. In my mind's eye, I imagine places like, Dartmouth Health and certain places that offer a lot of different services probably would maybe take advantage of that. In your opinion, who do you think would really take advantage of this new law? Do you think it would be a lot of optometrists, or would it be more of the larger providers? Thank you.
Thank you. At this moment, it would be primarily the larger providers. In fact, we do have one prepared to speak after me who would plan to offer that in their office, as they have multiple providers, multiple locations. Where I am located, it is something that I would like to be able to do because I am in such a rural location and access to care is so critical for my patients. I do not have the facilities right now to be able to do that. And that is something that I'm working to address, that as we grow, I would like to be able to do that. I think that it's not prudent to just kick it down the road until I'm personally ready to offer that in my office. There are offices that are available and able to do it now.
Other questions? Seeing no other questions, thank you.
Thank you very much.
Also signed up to speak is Scott Huffer from NHOA. Oh, and Dr. Sawyer, could you give us a copy of your testimony? I almost forgot. Sorry, I almost forgot.
It says to wipe down the microphone, but there's nothing to wipe it down with.
Oh, do we have anything, Christina, any wipes for the microphone? Just a moment, please. You're welcome to sit down if you want.
Sure. Sorry to be difficult.
No, that's fine. It's you're the first person who's actually raised that issue, so. But, oh, you did, okay, I'm sorry. Okay. I stand corrected. Thank you, Christina. Good morning.
Good morning. Good morning, committee members and Mr. Chairman. Thank you for hearing me today. My name is Scott Huffer. I'm an eye doctor and 1/3 owner of Focused Eye Care with offices in Nashua and Milford, New Hampshire. I am the immediate past president of the New Hampshire Optometric Association, the NHOA, and fellow of the American Academy of Optometry and a residency trained doctor of optometry. Focused Eye Care currently employs 7 full-time doctors and another 38 approximately support staff members. Last year, our providers provided care for 12,470 people. Suffice to say, we provided eye care to a lot of individuals. In my experience, it is very common to see patients who have not seen their primary care doctors in many years. I also see patients daily who do not have a primary care physician due to providers retiring, relocating, or the patient simply neglected to select to find one. I frequently see patients who report not having flu, COVID, and shingles vaccines, despite it being in their best interest. The shingles vaccination is probably the most notable, as shingles can cause temporary and permanent vision loss when involving the eye. Ideally, these patients would receive these vaccinations, but public health data tells us that they are not doing so. The shingles vaccination has been around for many years, is well tested. In adults 50 to 69 years old with healthy immune systems, this vaccine was 97% effective in preventing shingles. In adults 70 years older and older, it was 91% effective. This is a vaccine success story, but only about 30% of adults who might benefit from this have received it, and 1 in 3 adults over the age of 50 will get the disease. This is just one example of how adding another well-trained group of doctors into the mix of providers will help the state of New Hampshire improve health outcomes. Our patients come to see us as a matter of need so they can see to work and live better. We regularly educate them on smoking cessation, the importance of vaccines, and other important preventative measures, so it only makes sense that we could offer this if a patient is ready to do so. Optometrists could also be a critical component of increasing vaccination rates and decreasing disease burden across the state. doctors of optometry are fully capable of performing vaccinations. Intravenous and intramuscular injections are part of the curriculum at every optometry school across the country. An injection certification is an optional part of the National Board of Exam for Optometrists. Optometrists are currently authorized to perform injections in 22 states. I'm sure the biggest question anyone would have would be what happens if a patient suffers a severe allergic anaphylactic reaction. But emergency preparation is a critical process in all offices. In our office, we have always maintained emergency medications, an automated defibrillator. All of our providers are required to maintain CPR training and emergency training because it's required for licensed training. We also provide in-house CPR training for all our staff. It is not currently mandated, but we'll consider that in the future. Just like any doctor's office or pharmacy where vaccines are administered, we too rely on the emergency management system for otherwise more serious events. Luckily, this is very rare. Anaphylaxis rate for COVID vaccination is 11 per 1 million individuals, and for flu vaccinations, it's 1.35 per million individuals. Recently in our office, our preparation was tested. We had a patient suffer a severe seizure in our waiting room, and our staff handled the situation perfectly and appropriately as we expected and as we are all trained. So in summation, authorizing optometrists to provide vaccinations could safely increase vaccination rates and prevent significant disease across the population of New Hampshire.
Thank you. Could we get a copy of your written testimony, please?
Absolutely.
Questions? Yes, Representative Nagel.
I want to ask the same question. Oh, thank you, Mr. Chairman. Thanks for taking my question. The same question that was asked of Senator Rosenwald, but why just these three vaccinations? Why not others?
I would love to administer more. We had to work with our sponsors, and I believe incremental change is appropriate. So I believe in the future we'll show our merit and increase those to more and other vaccinations. But I realize this is a new change, and change comes slow. So incremental change is progress as far as I'm concerned. So we'll take what we can get.
All right, thank you.
Representative Murphy.
Great, thank you very much, and thanks for taking my question. My question would be, have you estimated what the cost would be for an office to set up for, say, COVID vaccines or any other vaccines? And the reason I ask that is oftentimes, if you look at other services offered, we think about the concept of a certificate of need, so that it's absolutely necessary in a certain area. Otherwise, you're incurring increased cost to your practice, which then can be transferred to a patient. So when I think about setting it up in the office, there's refrigeration, there's the training of staff, there is the reporting, so time is money also. So I'm trying to understand what the cost would be, how would this affect patients, how would this be transferred to patients, especially in light of the fact that the majority of patients or people in the state have access to the COVID, flu, and other vaccines currently available.
There's a lot in that. So have I done a cost-benefit analysis? Quick and dirty, not completely. Things like refrigeration and record keeping are things that happen every day in our office. We have lots of things that need to be refrigerated, and some are frozen. So that is something we deal with on a daily basis, and that would not apply any incurred costs. If anything, this is something that we're already doing. It would be an incremental addition. As far as cost of vaccination, no, I not being able to administer vaccinations, I'm not able to really appropriately look into the cost. We are a large office. We have many resources. I don't see it being a huge impediment. But if we are authorized, I can be sure we'll make it happen.
Other questions? Representative Merchant.
Thank you, Mr. Chair. Thank you for taking the question. In regards to looking through this from the eyes of a business venture, can you speak to how the office is going to handle shingles vaccines? My understanding is most of them are built through the pharmacy benefit side through a PBM. I know in a Part D, that's exactly where they have to go, because that's where a lot of patients end up in the pharmacy, is because of the fact that they have to be billed by the pharmacy or billed to the PBM side of the equation. Can you speak to that as far as with optometrists in the office and the billing system you're going to have in place, that you're going to be able to bill the insurance company for it and not charge the patient for it and then have the patient try to get reimbursed by the insurance company?
I can say we currently bill for all sorts of different medical services. It's always a challenge billing for any medical services. It does get complicated as we co-manage after surgical procedures in regards to cataracts and those rare occasions. Glasses can be covered by medical insurance, so it's not new territory as far as billing medical insurance goes. We haven't been able to bill for vaccinations, so it'll be a learning curve for sure.
That follow-up?
Yeah, yes, it will be. The reason I'm trying to bring this up is to be sure that I'm trying to protect the patient from them being charged by the optometrist, and then the onus is on them to try to get back reimbursement from the insurance companies, because vaccines specifically, most of them are billed on a Part D, which is a pharmacy benefit, not a medical benefit. So I want to make sure that the optometry community understands that the billing process is fundamentally different. And I just want to be sure that the patient ultimately is not the person going to be charged for it. It does go back to the billing process, and the optometrist will take care of that.
I can assure you that in my office, we wouldn't plan on balance billing anyone. But, we do this daily. There are procedures that we expect to be covered that aren't. Most of the time, it's not permitted to balance bill in our industry.
Representative Palmer.
So this is related to Representative Merchant's. Thank you for, Mr. Chairman, thank you for taking the question. I always forget to say that. Sorry.
Okay.
I just had my shingles vaccine, and I had gone in to see my primary care physician. I'm lucky enough to have one. He said, "Have you had the new shingles vaccine?" No. And I said, "Okay." And then I was waiting for the nurse to come back, and it's no. It's exactly what Representative Merchant said, is that for that office, which is in it's in a big clinic, to provide the vaccine, it's not financially reasonable for them to do that. So they just give me a prescription to go down to Rite Aid. And so my question to you is, would that be something you would be able to do in that instance if it's going to be an insurance issue? Just prescribe the medication so the patient can go and get their vaccine the way I did mine.
Representative Palmer, my understanding is they can administer it, but they cannot prescribe for it unless it's through their formulary. So I do understand where you're going. It makes a lot of sense. But the way this is written, they can only administer the vaccine. They cannot prescribe the vaccine to be given by somebody else.
Doctor, do you wish to comment, or? Okay. Representative Weber. Sorry.
Thank you. And thank you for taking my question. So I'll put the ball back in your court. It's my understanding that my optometrist prescribes medications for me regularly. My optometrist is cited in Vermont rather than New Hampshire. Do New Hampshire optometrists not have the ability to prescribe, or do they currently have the ability to prescribe some medications but not these? And clearly, we're solving an issue with prescribing with regard to the lacrimal gland here. So if you could explain to us what the current status is of prescribing authority for optometrists here, that would be helpful.
So, yes, we do prescribe medications, topical and oral, on a daily basis that affect the eyes with some limitations. I do not have the whole statute right in front of me, but I can tell you on a daily basis, I write probably 8 to 10 prescriptions every single day for oral or topical medications. The lacrimal gland was a previous exclusion. Hopefully we hope to have that going forward. But I believe it's to anything that's reasonable to treat the eye and surrounding tissue.
Well,
so I just wanted to explore a little bit more about this question about, is it preferable to have, for an optometrist to be able to administer the vaccine, or to be able to prescribe the vaccine, which could then be obtained at a pharmacy, or both?
Preferable for both. That said, the point of this bill is to offer it in office at the time, to administer the vaccination, to bring point of care to where the patient is instead of the reverse. I see access to care as a continuum, not an absolute. You know, if we can meet the patient where they are, the access will be better, vaccines will be more prevalent, and disease will be prevented, which is what the hope of this bill is. So the opportunity to prescribe a vaccination and have it later on, I think misses the point. The point here is to meet a patient where they are, to have the vaccine at the time, because what happens when we put something off? It doesn't happen. And when it doesn't happen across the population, people get ill and there's burden and illness that could have been prevented. So.
Other questions? Representative Palazzo.
Thank you, Mr. Chairman, and thank you for taking my question. I'm interested, how do you see the legal framework, especially around current very aggressive anti-vaccine hesitancy framework? So let's take a scenario that healthy 18-year-old male comes to you, and let's say you know that Department of Health and Human Services know that this demographic has increased risk of myocarditis after COVID-19 vaccine administration. And also, let's say you know that healthy 18-year-old is probably has very low risk of severe COVID. And if you have risk-benefit analysis, and let's say as a doctor you think that maybe that person don't need that vaccine, but would you be able to tell that client that you don't need it, because like then you causing vaccine hesitancy, and we heard that it's being frowned upon by licensing authorities. So I'm worried that we are opening to the situation when you won't be able to honestly say to a healthy 18-year-old that maybe they don't need a COVID vaccine shot. Could you comment? Thank you.
Sure. I mean, with any such procedure, you're going to have an informed consent. You're going to talk to this patient about the risks and the benefits, and for them particularly in their situation. And that person, I agree, is low risk, and there are some risks of side effects. So it's not my job to make that decision for him. It's to make him an educated person about the potential risks and the potential benefits. Obviously, risk tolerance is going to be very different patient to patient. And their interpretation of each of those risks may also be very different. You know, their personal experiences with COVID and myocarditis are going to influence a lot of their decision making. So it's my job to provide them the information on the vaccination and to make sure they understand that before I do anything. Yes, I think we're particularly adept at doing that. I think we have conversations with patients regarding treatment options daily. About risks and benefits, and certainly that would be an important part of that conversation with that individual. And it will go different ways with different people depending on their experiences in the past.
Okay. Other questions? Seeing no other questions. Okay, thank you very much. And again, if we could get a copy of your written testimony, that'd be great. I have no one else signed up to speak on Senate Bill 200. Does anyone else wish to testify? Seeing no one else, I'm going to close the public hearing on Senate Bill 200 and open the public hearing on, we are past the appropriate time. Open the public hearing on Senate Bill 236 and recognize the prime sponsor, Senator Shandley. Morning, Senator.
Good morning. Good morning, Mr. Chair, members of the committee. For the record, my name is Shannon Chandley. I represent District 11 in the State Senate. Those are the towns of Amherst, Milford, Merrimack, and Wilton. I come before you today to introduce SB 236. It is a bill that establishes a committee to study nonprofit organizations that contract with the Department of Health and Human Services. And this bill, some of you may have seen a version of this bill either the study committee version or a policy version of the bill. One of the problems that a number of this agencies that contract with the state to act in lieu of the state with regard to children in particular are running into insurance problems. They are concerned about their ability to be insured sufficiently. Some of the bills in the past have proposed a cap on the insurance. It was sort of like coming to the solution before the problem had been fully identified and considered. So this is a standard study committee that includes a member of the Senate, several members of the House, and should put out a report after looking at the issue. The Senate improved the bill somewhat with an amendment to define the scope, or actually it's a broader scope. It said the way it was in place prior, I believe it said the committee would study extending limited liability. The problem with that was that it was fairly prescriptive. It was identifying the solution before looking at the problem. So this way, the problem will be identified, the potential solutions considered, hopefully a particular solution recommended, and the report is due out in November of this year, I believe. Let's see, I just want to make, yes, this year. So the report would come out this year. I was talking to Representative Edwards, who thought that the bill needed to have a sunset date or a repeal of the committee. I am not sure that it is necessary. My understanding is once the bill comes out, or the bill becomes law, and that this report would be issued one time, and that would be the end of it. But if the committee does believe it's necessary to put a sunset or a repeal of this committee in place, that certainly is no problem. Obviously, the intent of the committee is to find a solution now and not continuing. Hopefully, a solution could be found this summer. I know that there are some folks from the agencies that are affected by this problem who are able to speak. They can probably answer any specific questions better than I, but I am more than happy to take any questions you may have.
Questions? Yes, Representative Netarapam.
All right, I'm feeling a little dumb. Thank you for taking my question. So, what is the problem here? I was trying to think of a nonprofit children's organization. And I was thinking like Nashua Children's Home.
So Waypoint, folks from Waypoint are here, and they can explain exactly what they are facing. But the issue is that because of the perceived risks in delivering this kind of care to children, whether it's foster care, working with any kind of, the risks that they face, that their access to insurance coverage is shrinking, and they are fearful that they may lose access to insurance coverage.
Follow up. So this isn't insurance coverage for the children. This is insurance coverage for the organizations that are liability for handling difficult cases. Thank you. I feel much smarter now.
And, well, my mistake, I should have been clearer.
Thank you.
Other questions? Yes, Representative Merchant.
Thank you, Mr. Chair. Also, thank you for taking the question. I do understand what Representative Edwards was saying, is that the way it's written, it's sort of implied that there's going to be a dissolution of the commission after November 1st, but would you be opposed to putting a sunset clause in there, basically to be clear that this is going to end come November 2nd, 2023?
Not at all.
Thank you.
Other questions? Seeing no other questions, thank you very much.
You're welcome. Thank you.
Also signed up to speak is Keith Koenig from Waypoint.
Good morning, Mr. Chair, members of the committee. My name is Keith Kinning. I'm the Advocacy Director at Waypoint. We sit here in support of SB 236. So Waypoint serves a critical role in the community by providing ISO level foster care. And this is foster care that we provide in lieu of the state doing this. These are children that have been identified as abused and neglected, and the state doesn't have the ability to serve them. We do. This is the most high-level intensive foster care that you can have. This is wraparound services that have kids that have gone through the most horrific parts of their life, almost unbelievable if you'd hear some of the stories. These services allow children to receive community-based services in the home. There is a critical shortage of ISO foster care programs in the state. And right now, we only have 8 of them. And the problem that we are finding is that our insurance company called Philadelphia has allowed us to keep our main policy, but they have pulled away our umbrella policy. So any lawsuit that involves us over $1 million, we no longer can get insurance for. We have sought out other insurance, and there is other insurance out there, but it is so prohibitively expensive as to almost be, it's the same thing as not having insurance. We get a certain amount of money every day to take care of these kids. And if the insurance is so high that we can't pay it because the funding that we get from the state has to go to the people that are taking care of these children, it's like having no insurance at all. So we sit here not as Waypoint, even though we're asking Waypoint is asking for help, we're sitting here asking you to help the kids because this is a program that needs to continue. And we just, because of everything that's happening, we can't get the insurance we need anymore in order to run the program safely, that any lawsuit wouldn't impact all the other programs that we have. We have over nearly 350 employees. We serve hundreds of elders in CFI programs. We serve the voluntary services. And right now, we are at risk that something that happens in our ISO program could spill over that would impact the entire organization. So what we are merely asking, and I know I've heard this from other committees, and I know the speaker is not crazy about commissions and committees. I understand that. But last year, this bill came before Children and Family Law. It made it that far. And a representative on the committee said, I will take care of this. I will work with the insurance department. We don't need to set up a committee. I bet I don't have to finish what I'm going to say for you to understand what happened was that never happened. There was no connection with the insurance department. There was no follow-up. And here we are a year later, and we're in just as much danger of not having the insurance that we need. I know Spalding has also had their insurance taken away from them. I believe Easter Seals, I believe Lisa Britt said she was going to send in testimony. Maybe she sent it online. But this isn't, again, just about Waypoint. This is a trend that's happening that agencies like ours are losing their insurance. And when we lose our insurance, we can't serve the children that need to be served. All we're asking is for a committee to look into a solution to this problem. I understand, and I would have to tell you, what would make me happiest of all is if everybody was happy with the solution and the kids were protected. That's the goal we're looking to go for. And so if this involves an insurance pool that somehow that providers of these services could do, or any other thoughts that people bring together, but we can't come to a solution to this problem until we all sit down and talk about this. And that's what we need to do right now. And this is something that if we thought this was a short trend, that it was going away, we wouldn't be sitting here bothering you. But because ISO is so important to these children, we would ask you to support this bill merely to establish a committee for us to look into how us and other nonprofits can find some kind of insurance company that we can continue to protect these children. So that is what I'm asking. And on behalf of the kids in these ISO foster care programs, thank you for listening.
Thank you. Yes, Representative Weber.
Thank you, Mr. Chairman, and thank you for taking my question. Just so I'm grasping the extent of the problem and the focus of the committee, when you're saying, when you're talking about the insurance, I see the issue of liability from an organizational point of view, and the impact it could have on other programs if there was a catastrophic event and a catastrophic recovery. The question I have is, does the insurance that you carry cover the liability of the individual ISO foster parents as well, or is that a whole separate problem?
Thank you, Representative, for the question. I can't answer that right now, but I certainly can get back to that. My understanding is this is the insurance for Waypoint. This is strictly for Waypoint, but I will check into that with our CEO and get back to you. And I want to make everybody completely understand, we are not looking for immunity. We are not. We are looking for the ability to buy insurance that we can continue to provide this program. But I will get back to you, Representative, as soon as I can.
Okay, Representative Shapiro.
Yes, thank you, Mr. Chairman, and thank you for taking the question. My limited experience with these study committees is that they identify the problem and make suggestions of some, recommend some possible solutions. And it sounds like you're way ahead of the game in regard to this, that you have a very specific problem that you're trying to address, and you are the experts on it. You know all about it. So that's not to say that we don't need a study committee, but I wonder if you did bring up one idea, but if you've done research into what possible solutions there are, or researched what nonprofits use in other states to deal with this problem.
Thank you for the question. We definitely know the problem because we've had our insurance taken away from us, and we definitely know we can't find insurance in an affordable range. I think, as I said before, there are many solutions out there. There are organizations that are here that have legitimate concerns about some of the solutions that might be proposed, and they may oppose that. And I think the thing that the committee would allow us is to get into a room and make sure, I think the last thing all of us want is to get to the end of the committee and come up with a solution that people don't agree with or that they fight against. I mean, our goal would be to find a solution that everyone around the table says, yeah, we can live with this. The insurance department, the different organizations, and we can put a bill in for this next session that would solve this problem. So I do think we need the weight of the committee to bring everybody together so that we can work together. This has been going on now for 3 years. We've brought the bill on numerous occasions, like last year. We thought we were very close until the representative said that he would take care of it. But I think you're right. We're very far along, except for that last piece is we don't have a solution that everyone agrees to. And I think that obviously is the solution we need to get to. I don't know, Representative, did that answer your question?
Follow up.
Yeah, yes, it does answer my question. And I would just say from, my experience that dealing with some of the kids and families that will be served by these, wraparound intensive needs foster homes is complicated enough. And it's very difficult to be successful with the treatment, that this shouldn't be one more problem that you have to address.
Yeah, and I would have to say my experience with the committee, one of the most impactful committees I've ever watched was Senator David Booten's committee on DCYF. That was Senator Booten who really moved things forward with a lot of the changes that happened to DCYF and funds going into DCYF. So I'm very optimistic that with people generally caring about the children, and both sides, everyone cares about the kids. We have different perspectives on how to get there, but I would agree with you. This would be nice not to have to worry about so much. We'd like to get past this and do the job which we do, which is send in 5, 6, 7, 8 people into these homes and give these kids wraparound services to save their lives. And it truly is what these children have been through. They need their lives saved. They need people to come in and help put their feet back on the ground. They need support of these foster care families. And certainly this is something administratively that if we could put behind us, it'd give us more time to focus on the children. So thank you.
Other questions? Representative Merchant.
Thank you, Mr. Chair, and also thank you for taking the question. What I'm struggling with, I see people from the legislative body on this committee, which is what a committee's for. However, I don't see other representation from the insurance industry and the stakeholder community. I think the intent here is probably to have them come before the committee and talk about it, but would you have any thoughts on having members who are voting members of the committee, it's kind of a hybrid between the two, where all of a sudden you have the voting members on the committee comprised of legislators, but also non-voting members coming from the insurance industry, coming from other stakeholder communities, because they're the ones that need to be at the table. It's not just legislative body, but the people at the stakeholder community, including yourself from that part of it, as far as the people from the insurance industry, people coming from that part of it. Would you, I'm looking at Senator Shanley down there as well, but I mean, I think it's important we have all the stakeholders at that table and not just have legislative bodies there.
If it's all right with the chair.
Sure, sure.
Thank you very much, Representative. My understanding is that traditionally a committee is comprised only of legislative members. And those members of the legislature, the Senate and the House, can then call on any experts in the field and all the stakeholders. Certainly, they would be charged with seeking out testimony from the insurance department, from the New Hampshire Association for Justice, from perhaps the various agencies, families that are in, anyone, any stakeholder. That would be the charge of the legislative committee. What you're describing would really be more a commission. It is a larger undertaking and a little bit less nimble. This bill really is for a committee, and I think a committee can do the job if it's properly chaired and orchestrated.
Thank you.
You're welcome.
Representative Weber.
As a follow-up to that question, would you believe that one of the most effective committees I ever sat on was chaired by, at the time, Representative Nancy Stiles, then she went on to be a senator, and it was on the issue of truancy, and she managed to assemble about 15 different constituencies that ranged from schools, school board, teachers associations, homeschoolers, probation officers, you name it, and came up with a very effective set of parameters. So it is a format that can be very effective, and that the experience on that committee was that the people who came, and they all came regularly to every meeting, had such a stake in the outcome that they were motivated to be there.
Yes, I would believe.
And I have a follow-up question. And isn't it true that if you have a commission that requires the appointment of outside people, and you start the appointment in July when the bill is signed, getting anything actually done by November is almost impossible?
Yes, indeed.
Thank you.
Mr. Chair, do you mind if I just say something? Sure. So, Representative, I just want to say to you, you have my word that as part of the committee, we will make sure that everybody that needs to be there, because it does us absolutely no good to get the end of this process and have somebody that we haven't invited come in and say, we don't approve of this. And so we'll be looking, anybody that we are happy, and we can work with the other stakeholders to make sure if they say, we think that these people should be here, they should all be there. And the committee has that power. And to call anybody, and we want to work with everybody that wants to be a part of it.
Thank you.
Other questions? Any other questions? I see none. Okay, thank you.
Thank you.
Also signed up to speak is Beth Margison from DCYF.
Morning, Mr. Chair, members of the committee. Thank you very much for allowing me to speak this morning. I am Beth Margison. I'm the General Counsel Legislative Liaison for DCYF. And for all of the reasons that the previous two speakers, including the sponsor of the bill, said, DCYF wholeheartedly supports establishing this committee to look at the reasons why insurance is so difficult to get for the children's organizations that serve our population. And that's all I have to say. I'll be happy to take any questions.
Okay, any questions? Okay, seeing none, thank you.
Thank you.
Also signed up to speak is Marissa Chase from NHAS. Or is it NHAJ? I'm sorry.
It means my handwriting is bad. Good morning, Mr.
better
Chair
than
and
mine.
members of the committee. Thank you for the opportunity to speak this morning. My name is Marissa Chase. I'm the Executive Director for the New Hampshire Association for Justice, which was mentioned. It's a euphemism for the trial lawyers. And I am the unfortunate naysayer of legislation that was proposed 3 years ago that would have extended the same sovereign immunity that the state enjoys, as well as cap on damages to these nonprofits when they contract with the state. We had serious concerns about that legislation. Been very happy to work with Keith to get to the study committee before you. And regardless if I am called or not, I will be at those committee meetings and offer perhaps unsolicited input. But, you know, I understand the, you know, the ISO foster care program is an incredible asset to the state, and it literally does save lives. I will also say that is a very small portion of the functions that Waypoint, Easter Seal, Spalding, et cetera, carry out. And when we talk about, you know, the issue of insurance, you know, two things that I hope are not contradictory. One, I remember when I was 16 years old, my car insurance under my parents' policy was very high for a good reason. I totaled my first car because I was 16 years old, so their insurance premiums were raised. However, this is also not the insurance problem that I believe these nonprofits are facing, and I don't intend to speak for them. I believe it is an insurance problem and not a lawsuit problem. There are very few lawyers in this state that do the kind of work that it takes to sue these entities or file suit. I believe Waypoint was only, and Keith, correct me if I'm wrong, only ever been named in a lawsuit once in the last 10 years?
Maybe twice.
But it is rare for many reasons that I can get into today or I don't have to. But anyway, this is all to say the bill before us has been years-long work that Keith and I have engaged in, and you know, we will be participating with the hope that, you know, everybody understands that this is not a lawsuit problem, that this is an insurance problem.
Okay, thank you. Are you taking questions? or-
Sure.
Do we have any questions? Oh, Representative McKay.
Thank you, Mr. Chairman. I would just like to comment that how impressed I have been with Waypoint over the years, that it's unquestionable their professionalism and commitment to the care of children. And I'm very pleased to see a former member be the chairman of this legislation. She's a good friend from the past. So that I would strongly support the passage of this legislation and be willing to participate in the work of it.
Thank you. Representative Shapiro.
Thank you, Mr. Chairman. I'm not sure I'm understanding your comment about this is not a lawsuit problem. I understand that. You're saying that these agencies have not been sued a lot, and that's why the insurance is so high. But so what are you saying is the nature of this problem?
I represent the plaintiff's bar, so the trial lawyers. Most of the time when we are in opposition to legislation, the folks proposing that legislation or vice versa are insurance companies. So I believe that, especially since the pandemic, while insurance companies have been enjoying huge profits, and I'm happy to provide the committee with studies that our national has done and surveys they have done across the country. While insurance companies are making record profits, their insureds are not seeing the benefit of those.
I get it now. Thank you.
Other questions? Seeing none. Okay, thank you very much.
Thank you.
Does anyone know if Representative Edwards is out in the hall or? He had to leave? Okay, thank you. I have no one else signed up to testify on Senate Bill 236. Does anyone else wish to testify? Seeing no one else, I'm going to close the public hearing on Senate Bill 236. Those are all of the bills that we had noticed for today. So we are going to adjourn and reconvene next Wednesday, at which time we have 2 Senate bills left. We will be hearing both of those. And then perhaps some of the more straightforward bills that we've already heard, we may be going into executive session on, and those will be noticed as well. So, thank you all.